thank you all for attending. This is our inaugural forum for the Caregiver and Patient Engagement Work Group of the North Carolina Serious Illness Coalition. So that's exciting for us. I'm going to just quickly do some introductions and some background information to give people a little bit of context about this forum before we get started into the presentation. For those who aren't familiar with our group or with the coalition, and I think Allison is going to put some information in the chat as we talk a little bit about why we felt that Dr. Miller's research was important for our work group in going forward with some of our priorities. So I am Karen Appert. For those who don't know me, I'm the current leader of the Caregiver and Patient Engagement Work Group of the North Carolina Serious Illness Coalition. And we are one of 4 work groups within the coalition. And we're very excited that this is our inaugural forum. So just a quick background about why I'm here. I'm a longtime caregiver of a mother with MS and dementia. And though my background is marketing, I'm switching careers to the aging field in part because of the inspiration I've had with having to piece together her care. So I come to this topic with a lot of passion and a lot of concern for caregivers everywhere who are going through a lot to support their loved ones. So a little bit of background about our work group and this forum that we're having today. For those who don't know, in April 2020, the North Carolina Institute of Medicine released a report, and it's called Improving Serious Illness Care in North Carolina. And I think Allison is going to put a link to that for those who aren't familiar with it. And within that report, there is a priority to establish a task force for those with serious illness across the lifespan in North Carolina. And that priority is one of the main priorities of our work group. And we've been working very hard in looking at some background information to understand a little bit more about what the landscape is like here and in other parts of the country, and learning about best practices and trying to see what other states have done to establish task forces. And as we've been looking at some of the research to learn where the gaps were, Dr. Erin Kent, who is part of our work group, told us about Dr. Miller's research, and it just aligns so perfectly with what we've been looking at. So that's why we thought this presentation would be an important part of moving forward in the attempt to establish that task force. So I just wanted to let everybody know that after the presentation, we'll do Q&A. If you can hold your questions until the end, or actually preferably if you would put questions in the chat or let us know that you have a question, or raise your hand with the reaction button. We're going to try to do a fairly orderly Q&A to get through it quickly, because I know we don't have a lot of time. So with that, I would like to introduce Dr. Erin Kent, who is a member of our work group. And we are also joined by numerous members of our work group. So thank you all for coming. So Dr. Kent is an associate professor in health policy and management at the UNC Chapel Hill Gilling School of Global Public Health and member of the Lineberger Comprehensive Cancer Center and Cecil G. Shep Center for Health Services Research. I had to practice that about 5 times before I could say it without stumbling over it. That's a lot. Her research focuses on the impact of social determinants on health outcomes for patients with serious illness and their families. Dr. Kent has over 110 publications in patient and family-centered outcomes research. I'm pretty sure she started researching when she was about 10. Along with being a member of this work group, Dr. Kent formerly served as program director and scientific advisor for the outcomes research branch at the National Cancer Institute. So we are really happy she's here and that she introduced us to Dr. Miller, and she'll now introduce Dr. Miller. Thanks.
Thank you so much, Karen, and thank you so much to all our work group members for being here today. It's my distinct honor and pleasure to introduce my colleague and advisee, Dr. Kate Miller. So Dr. Miller is currently a postdoctoral fellow at University of Pennsylvania in the Division of Medical Ethics and Health Policy at the Perelman School of Medicine. She's also a member of the Policy and Economics of Disability, Aging, and Long-Term Care Lab under Professor Norma Coe. and she's also an associate fellow at the Leonard Davis Institute of Health Economics. She recently received her PhD from Health Policy Management, my department at UNC, and she also was under the mentorship of a real powerhouse committee, Dr. Sally Stearns, Courtney Van Houten, Mark Holmes, and Donna Gillespie, and myself. And her dissertation was entitled Effects of Social and Financial Supports on Veterans Who Are Caregivers, the Physical, Mental Health, and Economic Status. And as part of this work, Dr. Miller researched the landscape of state policy supporting family caregivers, including long-term service and supports, which we talk so much about in our work group and in the coalition more generally. And she's going to cover that today. And I'll just note that our work group is so pleased to learn about Dr. Miller's research because it really provides context for how North Carolina is faring compared to other states with respect to caregiver education, training, and financial supports. So thank you so much, and please everyone give a warm welcome to Dr. Miller.
Good afternoon. Thank you so much for having me. I'm excited to be here and to share this recent work, and I hope it's useful to you all with your important work to improve care and support for individuals with serious illnesses in North Carolina. And so the focus of today's talk is really to describe the landscapes of policies that are systematically supporting family caregivers in the United States. And as Erin, let me share my screen. Can everybody see my screen now? Okay. So as Erin mentioned, this is building off some of my work from my dissertation. And so I'd like to just acknowledge Dr. Stearns, Dr. Kent, Dr. Van Houten, Dr. Gillespie, and Dr. Holmes for all of their guidance and input. They've contributed significantly to this. And any errors, of course, are my own. And I also just wanted to acknowledge my funding from the VA, the Caregiver Support Program, and the Quality Enhancement Research Initiative pertaining to this work. So first, I'm going to discuss who caregivers are in the United States and what they do. Then I'm going to introduce the recommendations to support caregivers put forth by the National Academy of Medicine in 2016. Then I'm going to review the federal and state level policies that currently exist to support caregivers and how these policies are or are not aligned with the National Academy of Medicine recommendations, where progress has been made and where there are opportunities for continued improvement. And then finally, I'm going to talk about what potential lessons may be learned from implementation of national policies and the VA Caregiver Support Program, and to what degree those lessons may be relevant when implementing state level policies to support family care. So there are an estimated 53 million family caregivers in the United States. And as the population continues to age, we expect a growing proportion of the population to be family caregivers at some point in time. We know that these caregivers provide care for an average of 4.5 years. And notably, the proportion of caregivers that provide care for 5 years or more, so this prolonged caregiving experience, that's a growing population. And we know that caregivers are also providing care to more care recipients. Since 2015, caregivers have also reported providing increasingly complex care, yet family caregivers are often unrecognized as members of the healthcare team. And so this is a particularly important point when we think about what systematic trainings are available to caregivers. Additionally, approximately 61% of family caregivers are employed, and they provide on average about 20 hours of care per week, and that's on top of their time at work. And in 2017, the estimated value of family caregivers was $470 billion, which corresponds to about 34 billion hours of care. And just to put that in perspective, Medicaid is the primary payer for long-term care in the United States. And in 2017, Medicaid expenditures for long-term care services were only $124 billion compared to the $470 billion of the estimated value of family caregivers.
Dr. Miller, can I stop you for a minute?
Sure.
I think we're getting some strange feedback from your mic, and I'm just afraid it's going to affect the recording.
I'm sorry, is that better?
Yes, much better.
So sorry. Thank you for
okay.
stopping me.
Thanks.
Um, so in 2016, the National Academy of Medicine produced a report called Caring for an Aging America. And experts put forth 4 policy recommendations in the United States to adopt to better support family caregivers and their care recipients. And the first recommendation is for states and federal agencies to address the health, economic, and social issues facing family caregivers of older Americans. Second, they encourage states to adopt policies and interventions that have been implemented successfully in other states. And the third recommendation pertains to creating a private and public partnership to fund research, but that's outside the scope of the presentation today. And finally, the last recommendation was for policies to explicitly address families' diversity with regards to race, family structure, et cetera, when assessing caregiver needs and developing interventions. So when we think about, well, what does it mean for a policy to support the health, economic, and social issues, the National Academy of Medicine broke it down and provided these additional 7 components for consideration. So policies that identify, assess, and support family caregiver needs, policies that provide payment reforms for providers to encourage engagement with family caregivers, training and capacity building of healthcare providers. So that can mean providing evidence-based supports and increasing referrals to community services as appropriate, increasing funding to existing evidence-based supports for family caregivers, providing economic support and expanding data collection to facilitate capturing experiences of family caregivers, and then evaluating caregiver interventions across communities in real-world settings. So in the United States, Congress has already passed several laws to support family caregivers, but systematic federal supports, including like comprehensive training, respite, and financial supports remain limited. In 1993, Congress passed the Family and Medical Leave Act, FMLA, which provides up to 12 weeks of unpaid leave for workers employed for at least 1 year at an eligible company. And we estimate only 60% of workers in the US are eligible for FMLA, but we also know that eligible workers may not take unpaid leave under FMLA due to the inability to afford income loss. So it really protects a subset of caregivers. Moreover, it protects a subset of caregivers as it only covers certain caregiver care recipient relationships. So for example, caring for a spouse, child, or parent. Now, in 2000, Congress passed the Older Americans Act amendments, and this established the National Family Caregiver Support Program, which then funds state initiatives to support family caregivers, for example, training and respite. In 2006, the Lifespan Respite Care Act was authorized to provide community-based respite care services for family caregivers, and an evaluation of the program found that states mostly used the funds to improve training for respite providers, create registries, and try to raise awareness about availability of respite supports. In 2010, Congress passed the Caregivers and Veterans Omnibus Health Services Act, which enacted what is the sole federal policy that does provide systematic supports for family caregivers, but it is through the VA. So of course, it's only for eligible caregivers of veterans. And I'll talk a little bit more about this program later. Finally, in 2017, Congress passed the Recognize, Assist, Include, Support, and Engage Family Caregivers Act, otherwise known as the RAISE Act. And this tasked the Department of Health and Human Services with developing a national family caregiving strategy, but as of today, no national strategy has been formally presented. States also have several mechanisms by which they can support caregivers. So for example, states can use Medicaid waivers, such as 1915 waivers, which are focused on home and community-based services, or 1115 demonstration waivers. An example would be the Balanced Initiative Program. States can also implement Caregiver Advise, Record, Enable Act legislation, also called the CARE Act. And that has 3 core tenets, which would require hospitals to record the name of family caregivers on the patient's medical record, to inform the family caregivers when a loved one is going to be discharged, and then to provide the caregiver with education and training for any medical tasks that they would be expected to provide upon discharge. And finally, states can adopt extensions of federal policies, so providing paid or unpaid leave, or expanding protections under FMLA at the state level. So what we did and what I'll talk about next to describe the scope of state supports is we looked at all 50 states and Washington, D.C., and we used publicly available data. So for example, we used the Long-Term Services and Support State Scorecard, where we extracted policies mostly focused on leave policies, unemployment insurance, employment discrimination protections, spousal impoverishment protections, and uptake of CARE Act legislation. We captured variation in the provision of training for family caregivers and any restrictions on caregiver eligibility through a report that was issued by the National Academy for State Health Policy. And then finally, we looked at the state tax credits database to capture variation in state level dependent care tax credits and whether or not those tax credits are refundable. So if you'll recall from a few slides ago, I talked about those 7 components that the National Academy of Medicine put forth about what policies would look like that are supporting the health, economic, and social challenges of family caregivers. And when we think about the policies that are available to us through those data sources, we can see that we can map them together. For example, CARE Act legislation could address multiple policy recommendations like identifying, assessing, and supporting family caregivers, whereas policies that extend protections under FMLA could provide additional economic support to family caregivers. So now thinking about the scope of state level supports. So this slide shows a graph of trainings available for family caregivers through Medicaid waivers. And so you can see here the states in the darkest shade of blue provide training for any unpaid or family caregiver through the Medicaid waiver. The 2 states in the medium shade of blue provide training, but there's restricted eligibility for the caregiver, and the states in the lightest shade of blue do not provide training through the Medicaid waiver. So about 47% of states do provide training, and of those states, 18 provide training to any unpaid caregiver or family member. 1 state restricts it to co-residing family members, family caregivers, and the other state only provides training to family caregivers related to the patient, but who are not legally authorized representatives. So for example, that would exclude spouses. Nearly half of the states with waivers providing training did so using an 1115 demonstration waiver, while the other states used 1915C waivers. Why does that matter? Well, the use of different types of waivers to fund trainings can have implications for access. 1115 waivers have to be budget neutral to the federal government. And so this can result in additional restrictions about who is eligible for those trainings. 1915C waivers do not have to be budget neutral, but they may use wait lists, and that can have an impact on the accessibility of training in a timely manner. And this is very much aligned with what we would expect, given some recent research from Dr. Bergdorf and her colleagues who found that in a nationally representative sample that only 7.3% of family caregivers reported receiving caregiver training. So next, thinking about the CARES Act legislation. Here in the map, you can see the states in the dark blue have passed some form of CARES Act legislation, and the takeaway is that most states have some legislation passed. However, there can be a lot of variation as to what that means. It's important to note here that CARES Act only pertains to family caregivers of care recipients who are hospitalized. And in an unpublished analysis of 43 states, only 12% of states' CARES Act actually addressed educating caregivers on medication management, while 51% of states included requirements to provide information about community resources to family caregivers. So there's a lot of heterogeneity, a lot of variation as to what this actually means. Additionally, and notably, Montana was the only state to indicate that caregiver support must be delivered in a culturally competent manner. So next, thinking about economic supports. This graph shows which states have dependent care tax credits, and the states in the darkest shade of blue have refundable tax credits, which means that people can get more money back, of course. And in the medium shade of blue, these states have a tax credit, but it's not refundable. And then the states in the lightest shade of blue have no tax credit. So why should we care about the tax credits? So tax credits can be used to help offset costs of caregiving, like home modifications. And caregivers recommend it in a report that was released this morning by the Rosalind Carter Institute. Tax credits for family caregivers had the greatest degree of support from a national survey of caregivers, and that is also aligned with the findings from the RAISE Act Advisory Committee request for information from family caregivers. Notably, Hawaii did a cost-benefit analysis about caregiver tax credits in 2007 and found that the benefit was greater than the estimated cost. But it is important to note that these benefits, these tax credits only benefit tax filing households. And there are several states currently pursuing legislation to pass dependent care tax credits. So this slide shows the variation that states have with regards to offering protections that exceed the federal requirements of FMLA. So that means providing care, covering employers who would not otherwise be covered, expanding eligibility of the employees, expanding the amount of time off they may take, or expanding the relationships covered. So for example, an additional protection would be allowing one to take time off to care for a parent-in-law. The main takeaway from this slide is that most states are in the lightest shade of blue and that they don't provide any protections. You can see that some states are doing additional protections, but there's overall a lot of room for potential improvement here. Next, this slide shows states offering any paid family leave or any paid sick leave. And you can see the states in the darkest blue offer paid family and paid sick leave. The states in the medium shade of blue offer paid sick leave, and the states in the lightest shade of blue do not offer either. And evidence suggests that paid leave increases labor force attachment of family caregivers. And even though more states are offering some form of paid leave compared to 2015, the number of states doing so overall still remains small. So one part of my dissertation that I worked on was developing a ranking of state supports for family caregivers as aligned with the National Academy of Medicine recommendations. So I do want to acknowledge the work of AARP in developing their state ranking for informal caregiver supports. This is different in that I've incorporated these additional data sources and focused on the leave policies, protections, and unemployment insurance policies as captured in the AARP state scorecard. And so here is the map illustrating the state rankings. The states in the darkest shade of blue have the highest ranking, meaning that they adhere the most to the National Academy of Medicine recommendations. And the states in the lightest shade of blue are at the bottom quartile. They adhere the least using this ranking method. Okay, so I do want to take a moment and talk about the fourth recommendation, addressing families' diversity and assessing caregiver needs and developing interventions. While no state policies from the data sources examined specifically referenced addressing family diversity, state policies should explicitly address family diversity with regards to family structure, as well as additional factors, including, but not limited to, race, ethnicity, sexual orientation, income, and gender identity as aligned with the recommendations. And in addition to differing experiences of caregivers by race and ethnicity, we know disparities also exist regarding caregiver intensity, such as hours per week. We observe it also with access to unpaid leave, with 7% of non-white employees reporting that they needed to take leave but unable to take it, compared to only 3.4% of white employees. And it also persists when we look at access to paid leave, with 26% of Hispanic and nearly 43% of Black non-Hispanic individuals having access to paid leave compared to 49% of white non-Hispanic individuals. The Diverse Elders Coalition collaborated with researchers to create specific recommendations, both for researchers and policymakers, to address the needs of multicultural caregivers. And their recommendations included, but are not limited to, the provision of financial support, equitable access to technology, and delivering culturally and linguistically appropriate supports such as translators, having sensitivity to perceptions of choice about caregiving and cultural history. So when we think about North Carolina specifically, there are an estimated 1.3 million family caregivers in North Carolina, with an estimated economic value of $13.1 billion. There are a myriad of caregiver supports in North Carolina. So the National Family Caregiver Support Program provides information to caregivers directly, as well as more broadly to the state to use. These are administered through local area agency on aging, and services provided can vary by county. There are some services available through UNC Lineberger, as well as Project CARE and the Duke Elder Family / Caregiver Training Center at Duke. And when we think back about the policies that were previously discussed, here's a summary of what it looks like for just North Carolina. And I do want to note that since the data was collected, North Carolina, there are 7 counties in North Carolina that have offered limited paid days off, paid family leave, and that's Buncombe, Durham, Mecklenburg, New Hanover, Orange, Person, and Wake. And then regarding spousal impoverishment protections, while North Carolina does have them, they are not as expansive as some other states. There is a wider range that North Carolina could expand to if interested. So then very briefly, I just want to touch on the VA Caregiver Support Program. The VA has a program of comprehensive assistance for family caregivers, and it is a clinical intervention that includes a monthly stipend as well as health insurance for caregivers, and the monthly stipend can be up to $2,000 per month, so it can be a sizable amount of money. There's also training involved. And more broadly, the VA Caregiver Support Program is implementing several initiatives which are aligned with the National Academy of Medicine and may be relevant to other healthcare systems or states interested in adopting similar initiatives. So for example, systematically identifying caregivers in the VA electronic health record system. Caregivers get their own record that's then tied to the care recipient's healthcare record. Caregivers are systematically assessed in training. There's a baseline training that all caregivers complete in the VA program of comprehensive assistance for family caregivers, and then there are additional trainings available based on their subsequent interests and needs. They systematically collect data on caregivers at the time of application or that initial entry into the program, and then annually, including outcomes like caregiver self-efficacy. How do the caregivers feel in terms of their own competence and effectiveness as a caregiver? They implement evidence-based caregiver support programs. For example, Caregivers First was developed through a randomized control trial. There are eligibility assessment teams and increased staffing, but of particular interest, they do extensive internal and external outreach. So within each VA medical center, as well as with community resources, the program has staff that reach out to make sure that caregivers can be referred and that providers are aware of how to do those referrals and what that process looks like. Notably, the VA also included caregivers of veterans as an eligible group for COVID-19 vaccinations when they first became available to formally acknowledge their role on the healthcare team. That said, there's definitely a lot of room for improvement within the VA as well, but these are some initiatives that might be relevant. Finally, I just want to close with, I did not examine policies enacted during the COVID-19 pandemic, but there certainly have been some that have been enacted to improve leave policies for workers. Most of these policies have been limited term. If they are adopted long-term, then the landscape could differ with an increase in support for working caregivers. But the key takeaways have been that family caregivers play an essential role in the delivery of long-term care in the United States. The landscape is improving overall, but it still falls short of meeting the recommendations from the National Academy of Medicine. There may be some meaningful insights and lessons learned from the VA, but of course, being cautious and extrapolating program components nationwide. There are several potential paths forward: expanding leave policies, improving financial support such as the spousal impoverishment protections and additional refundable dependent care tax credits, providing incentives to healthcare systems to actively include caregivers, and leveraging existing program infrastructure. So thinking about Medicaid and Medicare in particular are potential opportunities. Thank you.
Thank you, Dr. Miller. That was, wow, that was a lot of information. Very, very interesting. And also, I'm assuming other people feel the same way I do, somewhat disturbing on the North Carolina end when you see the maps go up of the US, and a lot of times North Carolina was in the light blue on a regular basis. So I have a couple questions, but I'm going to start with a question that Laura Jane Ward, who is a member of our work group, she put in the chat. She knew the rates of caregiver education were really low, but she did not realize it was about 7%. She wondered if you could share the study that referenced that statistic.
Absolutely. It was put forth by Dr. Bergdorf et al., and it was published last year, and I can send that if there's a way to distribute it after the.
And again, if anyone else has questions that they want to either put in the chat or raise your hand or unmute, we're happy to open the floor now to any questions you might have. One question I have is just related to what we just talked about, as far as what our work group is doing. We're working with the National Alliance for Caregiving on their 50-state initiative, where they're trying to do a unified state strategy, where they're the states that have done a lot around caregiver supports and task forces and alliances and coalitions and things are teaching other states how they can best do that. I wondered if in your research, in all the work you looked at with the different states and what the different policies are in those states, do you have any suggestions or any states that really stood out to you that you felt like were doing a great job? Because I really thought it was interesting that you went across the board. It wasn't just programs, it was economic feasibility, it was making sure caregivers aren't impoverished, or trying to help them not become impoverished by helping their loved ones. So overall, I know that's hard to maybe pick out one, but if you had to pick a state from each different section of your research done, do you have any suggestions?
Well, I think with the efforts to support economic well-being, Hawaii has been doing a lot of really interesting work. In fact, in 2018, they started a voucher program through their home-based services waiver. And I think that they've been doing a lot of really interesting work. Regarding the trainings, not a single, no state in particular stands out, not in a bad way, just I think that there are just a lot of trade-offs, and it would be interesting to have a little bit more information about how many caregivers are being trained through each of the waivers. Because of course, Medicaid waiver eligibility is a whole nother section, and we don't necessarily know, just because the state may have it, how many caregivers are actually being impacted by that. And that would be really helpful to further understand.
Hey, Kate, can you pick up your mic again, just because it's giving me a little bit, there's a little bit of interference.
So sorry. Could you hear me okay for that last one?
Yeah, thank you.
Thanks.
So we have another question from Harold Barnett. Is there any assessment of training content, standards, et cetera, an empirical evaluation of efficacy, and how is cultural competence defined?
So I believe that there's some work being done in that realm. I would be happy to share the recommendations from uh, the coalition that put forth the recommendations, the Diverse Elders Coalition, the collaboration with other researchers, and share that. I think there certainly is research being done, but I don't know if there's a clear definition, a clear consensus on everything that cultural competency would surround at this point.
And we have another question from David Sevier. He said, great to see that the VA is moving forward with caregiver support and that they are doing outreach. Can you give us an idea how extensive that outreach is and how it's going? And are there any connections with the academic medical centers that VA medical centers typically partner with around the country?
Sure. So with regards to outreach, I believe October is Caregiver Support Month in the VA. And so there are email blasts. Each facility usually has like a fair, for lack of a better word, where they usually sit up in a public area in the VA. They also do specific outreach to different service lines. So for example, if a VA has a particularly large rehabilitation service line, making sure that those providers are sometimes even brought onto the clinical eligibility assessment teams in the past, connections like that. And with regards to outreach in the community, that is one of the measures that's mandated by law. So they are evaluated by that. With regards to connections with academic medical centers, there are traditionally collaborations. I'm not aware of the VA caregiver support program at a specific facility necessarily having a specific affiliation with a medical with an academic center. At the Durham VA, the teams that worked on the evaluation for the VA caregiver support program also did work at Duke, certainly, on caregiver training.
Great, thank you. Okay, we have, this is great. Thank you for putting questions in the chat. I really appreciate it. Julian Montaro Rodriguez, who is part of our work group, asks, what do you think is the role of nonprofit organizations and health systems serving older adults in advancing caregiver support in North Carolina?
Absolutely. So community-based organizations, nonprofit organizations play a very important role. And I did not address them in this presentation simply because I took a national perspective and it was a little unwieldy to systematically identify and categorize community-based organizations, but they do play a very important role. Given the expected growth and demand, thinking about the aging population and for long-term care services, I do worry about too much of a reliance on nonprofit organizations and local communities. Regarding health systems, I think that they do absolutely play an important role serving older adults. And there are a lot of opportunities for health systems to include caregivers formally as part of the healthcare team, to enhance outreach initiatives. And there's a lot of pilot trials, and there is evidence about ways to do this and measures by which we can think about, well, is this intervention meeting our goals or not?
Great, thank you. One of the things that I have found intriguing recently, I think it was last year, Community Care Corps. Do you know about that? The grants they were giving out to local community organizations. And I saw that they just released another set of winners of those grants. And I just think that's such a great way. They're looking for innovative community organizations that are trying to do, again, the kind of the boots on the ground work, where to fill in some of those gaps. And I feel like that's so important. And I'm excited to see that there are innovative programs, and those programs are being rewarded with some funding to try to help, fill those gaps wherever they can. David Sevier says, this is a great way to, I don't want this to be the end of the conversation, but it's a great kind of a last thing. Well, David, do you mind if I hold that to ask a couple more questions? Because I think that's a great way to wrap it up. Okay. Elaine Whitford, I see, has a comment here. Hospital partnerships with nonprofits serving family caregivers will be key to moving the ball forward. Agreed. And I have a question related to that, related to the CARE Act. One of the things that kind of gets me sometimes when I look at the CARE Act requirements is that, it all has to do with hospital systems and the release from the hospital system. And there's so much of caregiving that gets done outside of the hospital system. In your research, were you able to look at some of those states that have adopted the CARE Act and see, I know, again, this goes kind of into the weeds, but are they, the states that adopted them, are the hospital systems abiding by the regulations that or the requirements that they're supposed to be following? Or are they, is it being done willingly, or are people, are the systems frustrated that they're mandated to do that? I'm just curious. I haven't really been able to hear, again, like actual reports of how that is actually going.
That is a great question. I have not seen that work, Dr. Kent. I know that your colleagues who were working on kind of the deep dive analysis as to what each state's legislation for the CARES Act entailed, they might be able to better speak to that. I have not seen anything drilling down at that level yet.
There is one paper I can find and forward that kind of gave like an incremental progress report that AARP put out, but then there's also some teams trying to do some more independent analyses. I think part of it is that it's still pretty new. So some of the states that have passed it just passed it within the last couple of years. And I think some hospitals systems have used it as sort of a like a they've taken a sort of a pioneering approach where they've said we're going to come out in front of this and really make this a flagship program of our system. And that said, I think in the earlier days of the CARE Act, I saw one presentation where a hospital system in New York said they set up this hotline system expecting to get people giving them calls, and their call lines were flooded. I mean, they totally underestimated the desire and the demand for services, and so they really had to actually kind of double down. And I don't know if Kate, you want to talk, 'cause part of my question was going to be about the uptake of the VA program. Like, what's the demand for services been like, and has the VA really been able to meet the demand?
The demand was a lot higher than expected.
Yeah.
In the first 5 years of the program, estimates were between 4,000 and 5,000 caregivers would be eligible. In the first 5 years of the program, they served over 30,000 unique caregivers. So the cost of the program exploded. The demand for the program was huge. GAO reports have, I think, already have well established that the VA did not struggle to meet demand, especially in the beginning. In anticipation of the expansion that happened last year, they hired a lot of staffing prior to the expansion in the hopes of, avoiding that again. And I think there are lessons learned from that.
Absolutely.
Okay, we've got another question. John Toma has asked, what can Medicare Advantage plans offer to provide support for family caregivers? Are Medicare Advantage plans using supplemental benefits to support family caregivers?
Great questions. So I will say my research has not yet looked at Medicare Advantage plans supporting caregivers directly. most of the work I've seen has been through Medicaid. I'd be happy to look into that further and get back to you about it. Regarding what could they do to offer support, I think one of the key questions is what outcomes do you want to obtain? So if you're focused on improving care for the care recipient, I think a lot of evidence would be focused on, would suggest that you focus on caregiver training, and making sure that caregivers have not only the necessary training, but any tools they have, home modifications, things like that, or access to home modifications. If you're focused more on caregiver well-being, some of those same policies and initiatives may apply, but additional ones may be more relevant as well. So it really depends on what outcome you want.
The other thing I was thinking about as you were talking about the National Academy's report that was done, I think that was 2016. And as you, I'm sure, are aware, the RAISE Council recommendations just came out the other day. And in going through some of those, I mean, again, a lot of it is very similar. It seems like, as I know, a lot of people who have been doing this for a long time feel that you sort of feel like, okay, these recommendations have been out there for a long time. Lots of people have been beating this drum, and we're making progress, but it just seems like it's inching along. But it will be exciting to see what happens as those recommendations come out, and hopefully things get done with those. And some of the really exciting, I think the conversation around caregiving with COVID especially has really put it front and center, which is nice. Let's see, do we have any other, oh, let's see, any AARP, yeah, AARP, yep. Yeah, Mark Hensley unfortunately couldn't be on the call today, but we are really, really happy to have some AARP people involved in this, and I know they're very strong across the country and in a lot of the states we've been talking to with NAC. So I'm going to go ahead and go back to David's comment and question, and I'd love to hear what you have to say about this, Dr. Miller. And that is, what one or two things would you do to advance caregiving support in North Carolina if you had a magic wand? I'm really interested to hear what you think.
That's a really good question. Again, I mean, I think it depends on what outcomes you're most interested in. I think based on the report from the RAISE Act Advisory Committee that came out last week and the Caregivers feedback, as well as the Rosalind Carter's Institute, caregivers seem to talk the most about employment protections and financial compensation for their time. So with that in mind, it seems like spousal impoverishment protections, and then any of the policies supporting like the tax credits, that was the most supported policy. So if I think listening to the caregivers and what they need and what they want is important. And so I would probably go with those.
And I think that that's what some of the people we've been talking to as well have said, that a lot of the calls that come in, whether it's at the local program level or at the state level, have to do with getting paid as a caregiver. And again, I think that's, I guess that's one of those things where, you know, now that the word is out that some states do offer that, and some counties offer that in the states that offer it, I think it's really hard, even for people who are doing it out of the goodness of their heart, which all caregivers have that, you know, it's still, there's, as you're giving up time to care for a loved one, it would be nice to think that you could be compensated in some way so that you're not losing income every time you have to take time off work. So that a lot of what you've talked about really matches up to what we're hearing in some of our conversations with some of those other states. let's see, I'm going to go back to the chat. If anyone else has any questions and they'd like to raise their hand and unmute, that's great. I'm going to go back and look through the chat and make sure I didn't miss anything. Harold Barnett. At IFC, Institute for Family Caregiving, we have an entrepreneurial response to this demand glut, which we think will be a major future trend. And he's put their website in there, so that's great. And that's something that, again, we're trying to work with as many groups throughout North Carolina that are focused on helping support caregivers in all different ways. We welcome anyone who's interested in joining this work group or the coalition. I went ahead and put the link to the coalition website in there if you're not already a member, or if you're interested in our work group or any of the work we're doing. And for now, the cost is free for now. So I'd say get in while you can. Anyone else have any questions? I don't want to keep everyone if we're questioned out, but I also don't want to get off too early. This was a lot of information to take in. Go ahead, Erin.
I would say the only other comment I think it's important, and Kate, some of your work has gotten at this a bit, is just to really think about the intersections between the direct care workforce and family caregivers. That there's a huge symbiosis there, and so when we think about policies on the national level, there's usually nods, and the RAISE Act certainly has a section on examining the relationships and how we need to be looking at and reforming, pay and salary and competitive entrepreneurial models for direct care workforce, as well as coming up with better economic and employment supports for family caregivers. So something to look at, and we also need to continue to look at that at the local boots on the ground level, like we have here in the Serious Illness Coalition. Lots of opportunities for, I think change, and some of that change may come in the form of awareness, just continuing to promote the experiences, the lived experiences of families as they go through serious illness, and continue to really shine a spotlight on that. And maybe, Karen, this is a good opportunity to mention our next event that's coming up.
Great idea. We are going, well, let me just say one thing before I forget. Thank you, Erin, for mentioning the paid workforce, because our friends at the Coalition on Aging are working with PHI on a pilot program right now and studying that landscape in North Carolina. And again, a lot of great information and a lot of you're right, those two work hand in hand. We need to have that direct care workforce in order to be able to provide some of the supports that family caregivers need. Related to our next forum, we are going to have another forum in October. I am sorry, I'm going to ask Allison for the date, and if you could put it up. I don't have the date off the top of my head, but we're going to be showing a documentary called Caregiver, a Love Story, that our friend Mary Lou Infinito, sorry to call you out, Mary Lou, but she introduced us to it a few months back, and we were all very moved by it. We now have access to it, and we're going to be showing it in October. Thank you, Allison. She put the link up on in the chat, and we're going to have a discussion afterwards after watching the short documentary. So we would welcome all of you to come to that. Maybe we can send information when we can send out information after this recording is up. We'll let you know where that is and can send out any of the other information we discussed. Dr. Miller, would we be able to share your slides? Would that be okay?
I think so. Yeah.
Okay. Well,
Thank you.
I'll check back with you to make sure that's okay before we send anything out. So if there are no other questions, and I'll wait for just a minute if anyone wants to say anything else. Otherwise, we'll wrap it up, and we'll hopefully see many of you next month at our next forum.
Thank you very much.
Thanks, Mary Lou.
Thanks,
And it's
everybody.
great seeing all the people that we know and some of the people we're not familiar with. So please come back. We'd love to get to know you better. Thank you, Dr. Miller, and thank you, Dr. Kent, for introducing this topic to us. This was a great first forum.
Yes, absolutely.
Thank you so much.
Thanks. See everybody later.